Welcome to a brief presentation on integrating cultural competence and humility into healthcare encounters, working with standardized patients and medical interpreters. Hi, my name is Isak Kim, and I am an assistant professor at the UB School of Social Work. My research interests are related to immigrants and refugee mental health, refugee-related trauma, post-resettlement challenges, cultural competence and humility in interprofessional education, and community-based participatory research. Providing best quality healthcare in today's diverse society not only involves learning about diverse patients, but also about diverse healthcare professionals that each of us are bound to work with in our future workplace. In this presentation, I'm going to address the importance of integrating cultural competence and humility into healthcare setting that is becoming ever so diverse and demanding close collaboration across multiple disciplines within and beyond traditional health professions. In particular, I will also address one educational training that is gaining more attention, which is learning how to work with patients who need a medical interpreter, such as immigrants and refugees. The role of culture in healthcare has been discussed in great detail. Culture shapes the way we approach our world and affects interactions between patients and clinicians. In particular, we must be mindful of the fact that the practice of medicine exists in a culture, which is a process through which ordinary activities and conditions take on emotional tone and moral meaning for both health professionals and patients alike. Let's take a moment to read through this vignette. While you're reading, pay special attention to your emotions and assumptions. After reading through the vignette on the previous slide, ask yourself, does this vignette bother you? How and why? What is it about the situation that implicate potential conflict based on cultural beliefs and/or practices? If there was a language barrier, would it change the nature of clinical interaction? Why and how? These are some of the difficult questions you will need to consider when you are working with patients who hold different viewpoints. In general, patient-centered care aims to promote understanding of patients' own experience of illness and treatment, and a strong rapport between provider and patient, while culturally competent care aims to reduce and ultimately eliminate racial and ethnic disparities in healthcare. Altogether, healthcare professionals should be asking themselves the question, what has to happen in the clinical setting so that patients feel welcomed on arrival and throughout the visit? Recently, people began to recognize underlying limitations of cultural competence training. While the intention was good, actual implementation of cultural competence training unwittingly encouraged stereotyping and discrimination, mainly because culture was seen and taught as a finite body of knowledge. If so, cultural knowledge was seen as something you can master. Instead, new concept of cultural humility tries to move away from physician as problem solver model and consider more dynamic, ongoing process of learning how to work with different patients. The cultural humility framework requires health professionals to critically examine their own discipline's culture and how it promotes or distracts optimal interactions with patients. The cultural humility also encourages focus on introspection and self-reflection as a way to begin to empathize with patients with different cultural background. All in all, cultural humility framework aims to foster the awareness of differing understandings of health, sickness, and the body. In a multicultural world where power imbalances exist, cultural humility is a process of openness, self-awareness, being egoless, and incorporating self-reflection and critique after willingly interacting with diverse individuals. The result of achieving cultural humility are mutual empowerment, respect, partnerships, optimal care, and lifelong learning. Traditionally, the cultural competence education and training have evolved around learning about other cultures. Although intention was good, as I mentioned earlier, mere learning about cultures other than your own often result in oversimplification and essentialization of a culture. This reinforced existing negative assumptions about culture and stereotyping people who identify with that culture. However, when embedded within the principles of patient-centered care model, with the infusion of cultural humility framework, cultural competence and humility education must be responsible for uncovering the presence and awareness of one's own culture, learning how to empathize with persons suffering, and recognizing structural and institutional disparities when it comes to responding to patients with cultural and linguistic differences. According to literature, the 4 basic elements must be integrated into the cultural humility education and training. First is critical reflection, which is considered as a starting point to recognizing the inherent power healthcare professionals have over patients. Second is learning from patients, which is consistent with patient-centered care model. Third is to develop and maintain mutually respectful partnership with patients and their communities so it can benefit patients through health advocacy. Lastly, it is important to recognize that cultural competence and humility training provides foundational knowledge that prepares each healthcare professional to engage in a lifelong process of learning and reflecting on their personal and professional experiences. Now I will focus on element of critical reflection. These are some of the first questions I ask you to answer along the way. To what ethnic, socioeconomic class, religion, and community do I belong? What about my cultural backgrounds do I wish I could change? Why? What experiences have I had with people different from me? What were those experiences like, and how did I feel about them? What is there about me that members of other cultures may reject? And what qualities do I have that will help to establish positive interpersonal interactions with people from other cultures? Another dimension of critical reflection is to recognize and learn about culture of health profession that you belong to. As I mentioned in earlier slides, each health profession have culture of its own, learned from hidden curriculum and through role modeling. The professional culture dictates certain customs, rituals, and the rules of conduct, thereby defining cultural milieu of a health profession. For example, let's talk about culture of medicine. One representation of physician as a cultural group is the white coat. It's a well-known symbol of medical profession, which is institutionalized in a time-honored tradition of white coat ceremony. The white coat originally and traditionally symbolized sterility, science, and healing. However, it also evokes personal meaning, both from doctors themselves and from patients about what it means to wear that white coat. Culture of medicine is also reflected in the so-called doctor talk. The doctor talk is characterized by statistical facts presented in terms of probability, gradations of severity, and the use of technical medical terminologies and acronyms. Although unintended, typical doctor talk tends to depersonalize patients and separate the illness from the person. In addition, while doctors present their own assessments as factual accounts, they often view patients' accounts as more subjective than factual, implying that there is more to it than what patients are telling their doctors. Last example of culture of medicine is physician's explanatory model. When applied to physician, it reflects their perception of the etiology, onset, pathophysiology, course and treatment of a disease process. However, when it is applied to patients, it describes how people conceptualize health, interpret the meaning of an illness, and its impact on their ability to function. Like medicine, culture exists in other professions involved in healthcare delivery. Can you think of examples that reflect unique culture of your own discipline? Once you have engaged in your personal and professional critical reflection, then you can have different ways to understand and deal with special challenges for refugee patients. Take, for example, language barriers that many refugees experience when accessing healthcare services. Because of limited English proficiency, healthcare professionals need help from medical interpreter in order to communicate with them. Many refugee patients also have different explanatory models of body, health, and illness. By practicing cultural humility, it fosters mutual respect rather than dismissal of their understanding, simply because it's not based on the Western notion. In the long run, refugee patients adapt to host society's culture to a certain degree. They blend the newly acquired cultural information of the host society into their traditional cultural norms and practice. One thing that can help in this transition is to find ways to improve their health literacy. The challenges include in that effort is several, but one of them is that many refugees who come from rural and conflict-ridden areas have low literacy in their own languages, which puts up additional barriers when learning new concepts, including health information. Coupled with complex Western healthcare systems such as health insurance programs and primary versus specialty care, it requires a careful but persistent approach to provide educational opportunity that is culturally and linguistically responsive. Based on the patient-centered care and cultural humility perspectives, it is just a good practice. Standardized patient with medical interpreters is a specialized clinical encounter simulation that offers experiential learning opportunity for health professional students in learning how to work with refugee patients with limited English proficiency. Through another video lecture, you'll learn how to best work with the interpreter in clinical setting. To summarize, these are essential questions to ask in order to engage in the practice of cultural humility with refugee patients who need medical interpreter. Particularly addressing power imbalances and asking questions like, what social and economic barriers impact a refugee patient's ability to receive effective care? What specific experiences are my refugee clients having that are related to oppression and or larger systemic issues? How do my practice behaviors actively challenge power imbalances and involve refugee communities? And how do I extend my responsibility beyond individual refugee patients and advocate for changes in local, state, and national policies and practices? In closing, here are selected references you can read up on regarding cultural competence and humility. Thank you for watching the presentation on integrating cultural competence and humility into healthcare encounters. I hope you enjoyed it.